Hello, good afternoon, and welcome. Happy Valentine's Day as we from the AHA are kicking off Heart Failure Awareness Week. My name is Kelly Macheska, and I'm the Senior Programs Manager for Heart Failure. And we're excited to have you here today. I represent the Quality Research and Analytics Department from the American Heart Association. For Heart Failure Awareness Week, we wanted to start off with a really important topics just to kick off our week, which is early detection of heart failure in patients. But before I get started, I'd like to go over a few items just to show on how to participate in today's event. This Lunch and Learn session is being recorded and it will be emailed out within 24 hours. It's in the GoToWebinar. Today's presentation can be downloaded in the handout section for the presentations that will be presented. They're in the control pane. All Dallin participants will be muted to allow speakers to present without interruption, and you will have the opportunity to submit text questions throughout the presentations today, and we will have a Q&A session after the two speakers present on the early detection of the heart failure patients. If you would happen to experience any technical difficulties during the presentation, it can be resolved most times by refreshing the browser, or if the issue is not resolved, you can IM us or following the refresh, log off and then log back in. Now, without further ado, I'd like to introduce our speakers for today. Our first speaker is going to be Dr. Daniel Foreman. He's a professor of medicine at the University of Pittsburgh in the divisions of cardiology and geriatrics, with facility appointments at the University of Pittsburgh Medical Center and also the VA Pittsburgh Healthcare System. At the University of Pittsburgh Medical Center, he's the chair of geriatric cardiology and also an associate director of translational research in the University of Pittsburgh Aging Institute. At the VA Healthcare System, he's a director of the research and Pittsburgh Geriatrics Research Education and Center, which is also called GREC. Dr. Foreman is currently funded by NIH and also the Veterans Health Care Administration with research interests that center around physical function in older adult populations and cardiovascular disease. So with that being said, I'd like to turn it over to Dr. Foreman, and then we'll formally introduce Dr. Manning right before her presentation. So Dr. Foreman, I'm going to kick it over to you. Thank you.
Super. I hope you can hear me. Just can you give me a nod or some recognition?
Yes, we can hear you.
Good. Well, I want to thank you. I want to thank the American Heart Association for this wonderful invitation. I want to wish everyone a happy Valentine's Day, and the focus on cardiovascular disease certainly seems apropos. And as you can see, my topic today is to discuss prevention of heart failure among the expanding population of older adults. The notion of prevention is topical, to be sure, for all ages, but as the population of older adults is growing, I think the issues of aging become more and more important to consider as a distinctive clarification or refinement of thought. And again, this notion of demographics is very important because the notion of what is a risk for heart failure is fundamentally changed by that context. And so in this graph, you see that longevity over years is changing. Longevity is increasing. In spite of COVID and current problems, the overall pattern is unmistakable, that if you look at patterns since really about 1950, there's a progressive increase of almost 30 years of longevity in our population, whereas in really 1940 or 50, it was typical to live to about 50 years old. Currently, the average is about 80. Longer in women than men, longer in some countries like Japan or Norway than America, but overall in most developed countries, the average longevity is approaching or is past 80 years old, and with a marked change in what it means to be older. Again, people are living 30 years longer than they did even a few decades ago. 30 years longer when the toll of risk factors and other factors that are associated with aging become more and more relevant, changing the notion of what is disease and when do we want to intervene. So if we look at cardiovascular disease relative to age, we see this dramatic pattern where it rises disproportionately as people become much older. And again, if you think about the population overall, the demographics, the population, because people are living longer, of those that are over 65 is growing massively. Currently, or by 2030, it's expected that 1 out of 5 people in America and even more in other parts of the world will be over 65, and the population 85 and over is the most rapidly growing demographic of all demographic subpopulations. And if we see here that the incidence of cardiovascular disease rises, and this is because of some of those factors that I've already alluded to, that things are happening as people are living longer. And this schematic, which has somewhat become like an icon of geroscience, represents the growing insight as to mechanisms, subcellular and cellular mechanisms that begin to accrue as people live 30 years longer and even longer than they did in the recent past. And as we see here, there are specific types of changes, genomics, telomere shortening, epigenetic changes, loss of proteostasis, and a variety of other effects that occur as part of normal aging, such that bodies change, phenotypes change, and the associated vulnerabilities to disease change, such that diseases like heart failure and other types of cardiovascular diseases are more likely to accrue. And continuing on the schematic of Carlos Lopez-Otin, again, 10 years old, almost 10 years old, it's not just that these things occur randomly, it's that genomics, telomere shortening, epigenetics, and proteostasis changes occurring as normal aging mechanisms have damaging effects. They interrupt normal physiology, and it leads to a set of predictable responses with nutrient sensing and mitochondrial changes that lead to overall phenotypic changes and associated vulnerabilities. So this notion of our bodies being stable is really not true. Our bodies are undergoing changes all the time, particularly in this effect of prolonged aging, as we see this in our population all around us. And many of you listening may be in this path of constitutive changes as a function of time. And this is a related schematic that shows that these changes that occur even in healthy adults amount to progressive risk towards disease. Particularly in this case, we're going to focus on cardiovascular disease, but this work by Ed Licata, who is the head of the intramural cardiac program at the NIH when he did this, shows that these diseases occur in a specific kind of pattern. So we see age on the x-axis and vulnerability with that hallmark notion of geroscience on the left. And we see that as one lives longer, they're ultimately increasingly vulnerable to diseases. The wavy lines are meant to represent homeostasis. And by this, Licata was emphasizing that not everyone ages the same way. Some people have more homeostasis than others, but ultimately the pattern is unmistakable, that as one lives longer, if one is lucky enough to live longer, he or she is more likely to have disease. And so cardiovascular disease in this context, but it's very distinctive compared to cardiovascular disease, heart failure, or other disease in young, and that occurs in a predictable context of multimorbidity, not just comorbidity, but multimorbidity derived from the same underlying substrate of vulnerability from aging itself. And a related concept is this notion of frailty, that separate from disease, but integrally related by the same physiology is this notion of frailty, changes of body habitus, changes of risk and overall responses to treatment as a result of the same underlying geroscience mechanisms. So when one thinks about heart failure risks and cardiovascular risks in general and typical aging, the same types of risk factors we think about, hypertension, cholesterolemia, sedentariness, tobacco, diabetes, they're all relevant. But the number one risk factor is age. It trumps all other risk factors, and those are the geroscience principles that I've alluded to several times already, because they are really the downstream effects, and they really compound the effects of the other risk factors in themselves, because as people are frail, they're less able to tolerate some of the other stresses, the homeostasis is no longer as robust, and the vulnerabilities are compounded. So this is a schematic that I've recently modified, so it's not quite the exact same, but it was published in JACC about a week ago, Journal of American College of Cardiology. And on your right, you can see that the cellular mechanisms that are kind of well known to the cardiovascular audience of inflammation, oxidative stress, give way downstream to cardiovascular disease and heart failure in general. But on the left side of your screen, you can see that those same types of constitutive changes are driving frailty, so that when one is older, he or she is intrinsically more predisposed to heart disease, but also frailty. compounded by the effects of their own individual circumstances of genetics and epigenetics and telomeres and proteostasis, and compounded by the effects of environment. But again, these patterns are likely to occur, and so this notion of what is predictive of disease and what is the best treatment to modify disease is really affected by that complexity. And one of the key factors is body composition. So heart failure, is both in terms of risk and treatment, is confounded by the fact that muscles and our skeletal muscle both go through predictable atrophy, and they also go through changes where even those among the cells that persist, there's increased interstitial adiposity with increased inflammation, with having a host of physiological changes, with changes of fiber types and perfusion and mitochondrial function, and all these things really augment or compound the vulnerability to exercise intolerance, to shortness of breath, and to other of the difficulties of heart failure, both in terms of risk, treatment itself once it occurs, and really compounding complexity. And this notion of fat as an integral notion of risk and outcome in heart failure is important to really, again, emphasize as a factor of aging. Fat cells increase, local deposits increase, particularly visceral fat, with a host of physiological changes of insulin resistance and inflammation, higher insulin, renin-angiotensin system activity, sympathetic nerve activity and such. And so that all of these effects kind of converge on the likelihood of heart failure risk. So this is another schematic that I've recently changed that was published in JACC that is really, it still preserves the same essential message that when one thinks about HFpEF in this case as kind of the banner child or the banner of aging, risk, and heart disease and heart failure particularly, we see that it's not just a damage to the heart from a heart attack or some specific insult, it's an accumulation of all these aging effects that I've been mentioning, the aging, the comorbidities, the inflammation, and obesity meaning really the changes to increased fat, even if somebody doesn't appear fat, the greater proportion of fat cells and physical inactivity. And it compounds with the fact that there's cardiac as well as multiple system effects, body composition and multi-organ dysfunction that is reinforced or exacerbated by the sarcopenia and the mitochondrial changes and capillary rarefication and endothelial changes, so that HFpEF more likely occurs. The notion that HFpEF is associated with hospitalization and death is bad enough, but in an older population, this notion of functional impairment and impaired quality of life and nursing home placement, these are issues that could really increase the complexity of treatment and disease management, so that these issues are really very specifically tied up with aging phenomenon. So again, I was asked to speak about risk factors in incident heart failure. And I want to emphasize that the traditional risk factors are still relevant: hypertension, cholesterol reduction, sedentariness. These are risk factors that are targetable and are modifiable. But as we think of the bigger context of aging phenomenon and the associated risks of heart failure and other cardiovascular disease, I want to introduce, and I will in a few moments, these notions of very innovative future targets for heart failure risk reduction. And this notion of caloric restriction is really not employed generally, but it's given many other types of caloric restriction mimetic strategies that can be used to potentially modify heart failure and other cardiovascular disease. And so with that, I just want to spend a few moments in this kind of quick overview to say that treating blood pressure is particularly important in an older population. The SPRINT data that I'm sure everyone in this audience knows to a good extent showed that more aggressive blood pressure reduction targeting 120 systolic or lower had huge benefits in terms of the primary outcome, which is a cardiovascular composite and all-cause mortality. And then related data by Jeff Williamson and Mark Supiano, they showed that in the older population, over 75, over 3,000 people, those benefits were even greater. Even looking at frailer subsets, the benefits of cardiovascular risk reduction were supremely high, heart failure reduction 38%. And this more recently published trial from China, looking at over 8,000 people, 60 to 80 years old, looking at a variety of blood pressure treatments, particularly an angiotensin receptor blocker with an even more aggressive blood pressure target, lowering systolic blood pressure, having an enormously successful treatment benefit for the cardiovascular outcomes, and heart failure declines, which were also extremely high. Actually, this is a typo. The heart failure declines were 78%. So excuse that typo. Dramatic heart failure risk reduction. But I wanted to express the trade-offs, because it's not that everyone should be treated to these super low blood pressure effects, that this work by Adam Bress highlighted the fact that among those that were treated to these low blood pressure effects in a study that he was performed that really extrapolated the data into a different population, showing that the side effects also increased with increased hypotension and syncope and electrolyte abnormalities and kidney dysfunction. So that there's a strong rationale for treating blood pressure in an older population because the inherent risks for heart failure as well as frailty are so high. But there's trade-offs because the population itself is so prone to vulnerabilities that you're kind of between a rock and a hard place, and it's the careful balance that requires a great deal of decision analysis in terms of who's going to benefit most. And I just want to emphasize that all traditional risk factors go through the same kind of composite of trade-offs, that the work that has gone on with cholesterol reduction has shown similar patterns. There's a well-known meta-analysis by Savarese that showed that among populations that were over 65, a large proportion, or the majority of people in that age group with primary prevention had less cardiovascular events. And that meta-analysis circulated for about almost 10 years before this study by Paul Ritger showed an even more robust analysis that showed, using the Jupiter and HOPE-3 data, showing that among the older subgroups, that the proportions of benefit were extremely robust, arguing a strong benefit in terms of coronary heart disease risks and cardiovascular death, which was used to infer that downstream effects of heart failure would also benefit substantially. And I want to highlight very quickly this more recent study by Ariella Orkaby, published in JAMA, showing a huge population of veterans, again, a primary risk reduction with statin therapy, showing strong cardiovascular benefits. And what she did in this study, which I think is particularly important, is that she showed that even in patients, or the population, they weren't patients at this point, this is primary risk reduction, over 90 years old, showing subgroups. And this is going to be the future, I think, of all studies, saying which older adults do very old subgroups benefit. And her work would suggest on this retrospective analysis that even people that are in their 90s benefit from risk reduction for both primary coronary heart disease events and downstream heart failure. And likewise with diabetes, treatment for treating glycemic goals has been somewhat mixed, and many people arguing that the risks of hypoglycemia in an older population may be disproportionate. The ACCORD data and many other trials have suggested this, but the most recent trials with the SGLT2 inhibitors have shown profound benefits even in patients that are older, independent of they're not targeting glycemic effects and relative instability from that, but they're treating endpoints that are really more cardiometabolic, particularly renal gains or renal function gains with downstream benefits of heart failure. So again, a variety of factors showing that both traditional risk factors and now with this potential focus on the SGLT2 inhibitors, the EMPA and dapagliflozin studies have shown that there's perhaps new ways that deal with the more comprehensive cardiometabolic aspects of aging that are relevant for heart failure risk reduction. This study by Wang, which was done with an international database, also highlights the fact that over time, the notion of what's the most important risk factor will change as a function of aging, showing that the metabolic risk factors are particularly for heart failure and other types of cardiovascular disease are particularly higher in younger populations, but as that one gets into the older subgroups of populations, the risks associated with lifestyle become more and more significant. And then again, this is a factor that as these risk factors accrue over now 30 or 40 years over what was once our normal longevity, there's more time for the destructive effects to accrue. And so with that, I really want to highlight the importance of physical activity and some of these newer, more still exploratory risk reduction factors as a way of modifying risk for an older population. So emphasizing physical activity, and I'm going quickly, but I think I'm preaching to the choir when I say that physical activity has been shown repeatedly in multiple studies to be beneficial in modifying risk for cardiovascular disease in general and heart failure. And so this notion of leisure activity and structured activity lowering the risk for heart failure has been well known in various epidemiological studies and cross-sectional longitudinal studies for many years, over a decade. But what's really become much more topical and much more recent is the notion that exercise is medicine, and it's not just pain is gain or just to go out and push as hard as you can, but to really think about exercise more in a more sophisticated and elegant fashion, to know what the targets are, to try to exercise in terms of mitochondrial performance in the skeletal muscle, and the heart muscle, and the vascular respects in ways that are much more specific. This involves both aerobic modalities, it involves strength modalities, it even involves more novel modalities like inspiratory muscle training, which all have been shown to have local and systemic effects. And it really raises new considerations for what's the best dose for an older population, and what's the best dose both in risk reduction and in treatment once patients might have heart failure. And I mentioned several times this notion of caloric restriction. And the reason why this really took off, very few people like this notion of caloric restriction. This is not starvation, but it is still restricting calorie count in a balanced diet. And there have been multiple studies that have shown that this is beneficial in terms of downstream effects of longevity, but also reduced cardiovascular disease and neurologic disease, because it triggers signaling pathways, molecular signaling pathways that have direct effects on some of the mechanisms underlying both aging and disease. So that if really one wants to modify the progression of aging, this is one very accessible manner to do this. And again, if it was more popular that people could reduce their diet happily, this might be very popular, but it has remained a little bit limited by the fact that most people don't embrace this as something they want to do. But it has set up a very rigorous thought process as how do we might achieve some of these same benefits with medications to essentially have a exercise in a pill form, and how do we modify these hallmarks of aging as a consequence. And this has really led to a lot of thought about modifying frailty, recognizing notions of patients that are frail, and likewise earlier effects of patients that might be vulnerable to heart failure, and to try to intervene perhaps with caloric restriction, but otherwise other types of exercise or other types of prescriptions that could modify this. And so this work by Luigi Ferrucci kind of just gives you a picture of where a lot of people developing these new drug strategies are starting to think. This notion of visceral obesity occurring in young adults, but particularly in adults as they get older, and which is really most of the population of the world, having all of these other signaling effects as a consequence, with the higher inflammation leading to these variety of cascading effects, with this notion of inflammaging as one of the hallmarks of aging, leading to cardiovascular disease and heart failure, but also leading to frailty and cognitive disability and physical disability as associated problems. And if we can recognize ways of modifying some of these pathways, perhaps it can really treat the downstream effects. So this is where the notion of exercise as a medicine starts to come in. What is the right exercise, and what are the novel therapies that could be used as a substitute to exercise or in association with exercise to improve those outcomes? And that's opening up like a box to a huge amount of research that's going on now, and by both pharmaceutical companies and in most universities throughout the world. This is an issue for the United States, tying it to efforts everywhere, as people everywhere are dealing with an aging population. And I just want to highlight this one study. This is just one of many, but this is just getting off the ground by the National Institute of Aging, looking at metformin as one of these caloric restriction mimetics. And the notion is that metformin will have robust effects on AMP kinase, one of these signaling cascades, with downstream effects of longevity, but also, again, as a very novel way of thinking about heart failure risk reduction in a completely new way than we thought about in the past. So again, this is not ready for prime time, although I think many of you probably already know studies or people that are taking metformin as a way of improving their aging process. It's already kind of seeped out into the web interest, and many people are interested because this drug already exists as a treatment for diabetes, but now it's being applied in a completely different way as a way of modifying aging and risks for downstream effects. So in summation, to what is a really kind of a rapid talk, is that the population of older adults is growing, the demographic is huge, and that this population is not just, you know, a subgroup. These are people that are uniquely vulnerable to incident cardiovascular disease by biological changes that go along with aging. And so traditional risk factors have sustained an even greater benefit, like treatment of blood pressure to be sure, but probably cholesterol and diabetes and sedentariness. But they have even greater benefits in the midst of the risks associated with aging and all the biological factors that are relevant. And I want to just, again, allude to the fact that there's a whole new smorgasbord of new ways of thinking about treating aging and modifying risks for heart failure and other cardiovascular diseases and other diseases in general as targets for risk modification. And that'll be my next talk, perhaps for this audience and others, as this world is really exploding throughout the world. Thank you very much. It's really been a great pleasure to be here.
Hey, wonderful. Thank you, Dr. Foreman. And we will have plenty of time for questions and answers after our next presentation. Without further ado, I'm going to have Suruthi pull up the PowerPoint presentation for us to share, and we'll advance for you, Dr. Manning, and I will go ahead and do your introduction. All right, Dr. Manning is currently a cardiology fellow at Northwestern University, Feinberg School of Medicine. She received her DO degree from Nova Southeastern University and completed her internal medicine registry at the University of Miami Jackson Memorial Hospital. Throughout her training, she's fostered a passion for heart failure. During her postgraduate and residency training, she collaborated with the Laboratory for Study on Neurohormonal Control of Circulation on products involving the region of aldosterone detrimental effects in heart failure, and the later transition from basic science research to clinical outcomes. She is interested in advanced heart failure and transplant, and her long-term goal is to pursue a career in academic cardiology with research focus on advanced heart failure and healthcare disparities. So Dr. Manning, I'm going to turn it over to you, and welcome. Thank you for agreeing to present for our team today.
Hi, thank you so much for the invitation and for the kind introduction. I'm delighted to be discussing such an important and passion of mine topic with the audience today. And Dr. Foreman, that was a fantastic presentation, so thank you.
Okay, go ahead.
Perfect. Today we're going to be discussing a little bit on prevention and early detection of heart failure patients. Next slide, please. So this is just a little bit of background in terms of the heart failure burden as of now. This is an analysis from the National Health and Nutrition Examination Survey that looked at 2015 and 2018. And what they found was that an estimate of about 6 million Americans 20 years of age or older suffer from heart failure, which was increased from about 5.7%, million Americans in a prior study. This graph represents here the breakdown in terms of heart failure prevalence in terms of age and sex. And as you can see here, the older the patient population, the higher the prevalence. And in patients 80 years of age or older, there are more females in terms of gender. Once heart failure develops, the results in significant morbidity and mortality with a 1 year mortality rate as high as 7%, and the 1 year hospitalization rate for a new diagnosis of heart failure is about 30% in patients with this chronic syndrome. Next slide, please. So in terms of traditional risk factors, when we think about risk factors for heart failure, are the same traditional cardiometabolic risk factors for aortic cardiovascular disease. And we're looking at coronary artery disease, diabetes, obesity, smoking, all of which account for about 50% in terms of the incident heart failure, with population attributed risk as shown in this diagram here. Again, data from the National Health and Nutrition Examination Survey demonstrated that about 1/3 of the US population adults have at least one heart failure risk factor. But to me, the most concerning finding was that many of these patients, despite having the risk factors of heart failure, were not being appropriately or adequately treated for their risk factors. And I think that it speaks to our lack of recognition for stage A heart failure, which is defined as patients without clinical signs or symptoms of heart failure, but related comorbid diseases or risk factors that confer a risk for developing heart failure. So I think there is a huge opportunity here for us to really go down to the prevention level. Next slide, please. Okay, so in terms of what are the differences? Are there any difference in terms of risk factors? Yes, they are. Gender and race difference in heart failure risk are well known. And this is a study published in JACC that demonstrated that in patients, female patients, hypertension is actually the most common risk factor and confers the higher risk. And for male patients, coronary artery disease seems to be the greatest risk factor for heart failure. In terms of racial differences, I didn't put that information in the slide, but I wanted to highlight that the Health ABC study demonstrated that patients, in terms of race, the population attributed risk for heart failure based on modifiable risk factors was significantly higher among Black patients compared to white patients. We are looking about 69% versus a 49% respectively. So with this in mind, let's just dive into some of the data we have regarding the risk factors. Next slide, please. Hypertension. Those foremen alluded to this. Long-term treatment of hypertension, it's known to reduce the risk of heart failure by about 50%, and it's associated with lower heart failure mortality. He kind of like highlighted the SPRINT trial, which it's well known in the heart failure community. And yes, we did observe a benefit in terms of heart failure events across all key pre-specified subgroups in patients that were treated to a target systolic blood pressure of less than 120. And I think the most important point to highlight here is that it's not only about controlling the blood pressure, but doing so with antihypertensive drugs that have been shown to reduce the incidence of heart failure. And we have a lot of studies, including the HOPE trial, that showed ramipril decreased the rate of new onset heart failure from about 12% to 9%. And that was consistent among patients with and without a history of MI. Here we have data from an analysis that included about 223,000 patients in terms of antihypertensive regimens most efficient in prevention of heart failure development. And what we found was that regimens that include diuretics, ACE inhibitors, or ARBs were the most effective strategy in terms of heart failure prevention. And among these, you can see the odds ratios of these agents. Diuretics were the most effective drugs. Of note, calcium channel blockers and beta blockers seem to be less effective as a first-line antihypertensive when we're talking about heart failure prevention. Next slide, please. So diabetes. Diabetes interacts with every cardiovascular disease at every level. And despite the lack of a really profound understanding the pathophysiology between diabetes and heart failure, we know that they're interconnected. We know that poor glycemic control, longer duration of diabetes, insulin treatment, and the presence of microvascular complications related to diabetes have all been associated with the development of heart failure. So it's very important to control the diabetes in our patients with the goal of preventing heart failure. And how can we have a talk on diabetes and heart failure and not mention at least briefly SGLT2 inhibitors? These drugs have been on the headlines now for quite some time. But I want to point out here that I'm not referring to SGLT2 inhibitors in terms of the newest data in terms of mortality benefit in patients with established heart failure. We're talking about prevention. And if we think back to like the first initial trials involved in these drugs, the Clarity 58 EMPA-REG outcome trial, we saw a reduction in heart failure hospitalizations in patients with diabetes and established atherosclerotic vascular disease or not established atherosclerotic vascular disease. In fact, most of the patients in those trials did not have heart failure at baseline. The range was between 10 to 14% only. So we're looking at primary prevention, if you will. This is an area where we can actually make a difference in terms of primary prevention for heart failure. Next slide, please. Dyslipidemia, we know there's a lot of data, and this is a classic. The Framingham Heart Study show an enduring relationship between lipid concentrations and heart failure incidence. there was an inverse relationship between HDL levels and heart failure risk, which persisted even after adjusting for confounding factors. And this is the Kaplan-Meier curve from that study that shows that in patients in the intermediate and in the high baseline HDL groups categories, there was a 23 and about 40% lower risk of heart failure, respectively, compared to patients in the lower end of the HDL group. So again, if our patients have hyperlipidemia, it's really important to get those cholesterol levels under better control with the goal of preventing heart failure. Next slide. Smoking. I mean, smoking use dependence. There's a strong evidence in the medical community and the community in itself that tobacco use is associated with cardiovascular disease. So I want to point out two important points here. Number one is that for those patients who are now considered former smokers, the incidence of heart failure is the same to that of someone who never smoked after 15 years of tobacco cessation. And this is a question that a lot of our patients, at least I have encountered in clinic. And it's important to provide them with that information and use it as a kind of like motivation for them to quit smoking. But I want to highlight that tobacco dependence is a chronic disease. And in my opinion, a 20-30 minute follow-up visit or a brief hospital encounter, it's not sufficient time to really help this patient, motivate these patients to quit. And we have to be aware there are multiple resources, professional counseling groups, there are group classes, there are hotlines, nicotine replacement. There's multiple resources that we can use and combine to really give our patients the avenue for a successful pathway to smoking cessation. Next slide. And this is data on physical activity. Again, this is a meta-analysis about 10 cohort studies that comprised 282,000 patients that were followed up to 30 years. And what we saw was a risk reduction for heart failure among patients with a regular exercise pattern for up to 28% lower. Next slide. So if we take a step back and we just think about everything that we have briefly discussed, I think that the key preventative strategy for heart failure is to promote a healthy lifestyle through life. You know, to promote physical activity, to promote smoking cessation. And if the patient has a diabetes, the hypertension, the hyperlipidemia, we should just target a really good control of those risk factors. Next slide. Now, I think it would be a disservice to all of us to have this chat without briefly touching up on a very important topic, that of social determinants of health. I think the COVID pandemic made it very clear that social economic inequalities do exist and are strong determinants not only of cardiovascular risk, but also outcomes. So I think it's important, of paramount importance, to address these social factors when we are trying to target and promote a healthier lifestyle among our patients. These are clinical statements from the ACC and AHH guidelines on the primary prevention of cardiovascular disease. And it kind of like highlights a few tips that you can count on in terms of when addressing these topics with our patients. What are the things to look out for? And I won't go over all these details for sake of time, but I just want to just go over briefly, like a hypothetical patient. You have an elderly patient in clinic with hypertension, diabetes, hyperlipidemia, obesity, and you want to promote healthy lifestyle. I think it's important to just not go in and just list a few things that the patient we're expecting or we want our patients to do, but really take a step back and understand who that patient is. Does that patient lives in a safe environment, in a safe neighborhood where they're going to be able to go outside and walk? Because if that's not the case, I think it would be not very fruitful to say, okay, let's go have a 30-minute walk every day. In the same way, like, does the patient live in a food desert zone? What are the financial situation for these patients? Who's actually doing the grocery for these patients? These are all things that if we really take into account, and only by truly understanding this social determinants of health, we'll be able to make a positive impact in their conditions. Now, if we can just move on to the next slide to discuss a little bit of moving from risk factors to just recognition of heart failure. And again, early heart failure recognition has been shown to reduce heart failure related morbidity. But patients may present with a variety of signs and symptoms that are either non-specific nor sensitive for heart failure diagnosis. So I think it's important to have a high incidence of suspicion. You know, most commonly we are all very familiar with the dyspnea or tonia, the PND, the fatigue, usually in like JVD on our exams. We find that S3 gallop, weight gain. But again, I think the most important is just to take a step back and put all of this into context and see like, the progression of our patients, getting to know our patients. And I wanted to highlight that as a result of compensatory upregulation in lymphatic drainage, some of our patients are not going to present with the classic crackles or peripheral edema that we usually see in heart failure patients. Next, please. In terms of diagnostic tools, you suspect heart failure in a patient, let's start with ordering basic blood work and see what are those risk factors of the patients. Where does our patient stand? In terms of more specific cardiobiomarkers for heart failure, we have the natriuretic peptides, whether that's BNP or NT-proBNP. These are very useful in the diagnosis of heart failure and also in trying to assess the severity and risk for these patients. In terms of diagnostic imaging, we have chest X-rays can be very helpful, but we ultimately are going to need that transthoracic echocardiogram to really assess the cardiomyopathy of the patient. Where is that patient in terms of the heart failure? And a lot of these patients will have ischemic cardiomyopathy as the underlying etiology, so they're going to end up going for coronary anatomy stratification. Some other things that we can consider is the cardiac MR, endomyocardial biopsy, and these are more on kind of like an individual basis based on what are the risks for your patients. Next slide, please. And this is my last slide, and I wanted to bring this up because I'm very passionate about this, and I think this is a fantastic study that was published in Circulation Heart Failure relatively recently, and it's a retrospective analysis that they are using an administrative database of health claims of patients with not only commercial but also Medicaid Advantage health plans, and it covered all 50 states. And this study looked at 2003 all the way to 2019, and what it showed was that a large proportion of our patients are being diagnosed with heart failure in acute care setting, meaning we again are missing the opportunity to diagnose these patients with a stage A, B, a little bit less of an acute setting. And more importantly, it demonstrated critical disparities in the diagnosis of heart failure. Female race, female sex, Black race, and low net worth were associated with even a greater proportion of these patients being diagnosed in the acute care setting. So I think this is, if you want to take something away from this talk, take this. Let's just make sure we're identifying our patients when they're stage A. Let's make sure that we're not forgetting about our female patients, our Black patients, our patients with lower socioeconomic status. And let's just put everything together and trying to make that prevention since day one. And with that, I want to thank you for your time.
Wonderful. Thank you so much, Dr. Manning, for that presentation, and Dr. Foreman. Now we'll begin taking a look into the control pane. So if anybody has any questions, we're going to have some panel time for our two great presenters today. Super excited to review the content and the content that was shared to really kick off our Heart Failure Awareness Week in the presentations. So I will turn this over to the team and see if we have any questions in the control pane area. And then just as a reminder, as we're tallying up those questions, we are featuring other events this week and topics. Just to I'll do a shout out for those real quick. We're going to have social determinants of health for the heart failure population. That's going to be tomorrow. Wednesday is going to feature certifications at the heart and around heart failure care. On Thursday, we're going to have patient and provider resources and heart failure tools that you can use. And then Friday, we're going to have a quality improvement focus and reflection, and also on recognition criteria. So just wanted to do a shout out. Each day we'll be doing these lunch and learns at 1 p.m. Eastern Standard Time. So team, I will turn it over to you. Let me know what questions we have in the control area. Thanks.
Kelly, I'm seeing some hands raised, so if we could just remind everyone to please type your questions into the chat box, and we'd be happy to read them to the speakers. Okay, so we did have a question come through. What are your thoughts of how to identify HFpEF patients in the ambulatory care setting? So Dr. Foreman or Dr. Manning, if you'd both like to take a chance at answering that, that would be great.
Do you want to start?
Sure. Thank you. I think the most important is to take a kind of like a step back in high incidence of suspicion. If you have these patients that are more fatigued, more like short of breath, and they have like the hypertension, maybe some valvular disease, some family history, I think that's like kind of like the red flag to start like analyzing, well, should I proceed with an evaluation? I think ordering a BMP in the clinic can be very helpful, kind of like guide you and kind of like go from there.
So thanks, and I'll follow up. Following on Dr. Manning's discussion about stage A, I think most people, once they reach 65, are stage A, and many are stage B already, just as a function of aging and all the changes that go along with aging in terms of aging, normal aging cardiovascular responses, in terms of some of the remodeling effects and other systemic effects that contribute to heart failure. So I think one of the things is to really think about that as you're examining any patient that may have symptoms of shortness of breath or fatigue, as was just mentioned. Heart failure, HFpEF particularly, just doubles in prevalence every decade as once people hit older age. And so I think that the notion of concern and intervention becomes very high. BNP is important, but it doesn't always correspond to HFpEF because it's not as reliable as heart failure with reduced ejection fraction, where there's stretching of the heart. So I think clinical judgment is very keen, knowing that body composition and other risk factors are really accruing as a function of normal aging and really tip very easily into HFpEF for reasons that are really now really trying to be untangled, and that really has to do with some of the mechanisms of aging that may predispose on a more fundamental level. So I think treating, particularly thinking about volume load and diet, become really very important, and not to be dismissive as people get older.
Great, thank you both so much. We did have another question come through. How often is heart failure missed in COPD or emphysema patients in the outpatient primary care setting?
I mean, I can start, but there may be a better answer. I think it's missed a lot for the reasons I was just saying. That I think, again, in an aging population, but really a multi-morbid population that really is independent of age, these diseases often occur together. The heart and the lungs are very close to each other, and the pathophysiology really of one compounds the other. Most people with heart failure have issues with their lungs, and and it's very and frequently I think for the patient it becomes somewhat overwhelming, because you have these specialists that come swooping in, and they give they each blame the other system. And so the patient is left in the middle, somewhat frustrated that no one's really taking care of their symptoms. So I think really the answer to the question, I think, is that they're frequently missed. And I think the approach is to really work together, in many cases kind of in a trial and error, treat both, and try to see which has the most success in modifying symptoms. But I would be curious, Dr. Manning, if you could add your perspective.
No. I mean, I couldn't agree more with you. I think we're often in a battle where we blame the other system for our patients' conditions. And I think it's just important just to take a step back and say, well, it's not clear here. Let's just optimize both. What can you do in terms of optimizing the heart failure side component of it? And if that doesn't work, then, well, we're looking more at respiratory component. But take a step back. Always take a step back and trying to really see the course of the disease for the patients of the presentation, and trying to tease out what's the most prevalent symptom there. And are you making changes and you seeing any positive results? Maybe that helps you. If you're not, maybe you need a little bit of help from the pulmonologist. But I think it's missed. I do. I don't have the data in terms of how many patients are missed, but I think sometimes it's so confounding that it gets missed. And then the patients end up, again, in the acute care setting being diagnosed with the heart failure.
Thank you both for sharing your perspective on that. We have had a couple of other questions come through. So what is your experience with palliative care? Early and often discussion about quality of life. So what your experience with palliative care recommendations have been. So Dr. Manning, do you want to start, and then Dr. Foreman chime in?
Sure. Actually, that's another topic I'm very passionate about. I think that as of now, and there is a lot of studies here that say that we're not including palliative care discussions or including the palliative care team early enough. And I think the moment you have your heart failure patients and they're starting to tilt up to that advanced heart failure category, you just get them in. Get them in just to understand your patient more. See what's the goal of the patient, not only your goal. Yes, we want our patients to get better. We want us to just do as much as we can to improve the long-term outcomes, but take a step back and think, okay, what's important to this patient? How can we make that happen? And I think the palliative care team has a lot of resources that sometimes we're not even aware of that will make a difference with those patients. It's not just about like the mortality or the heart failure hospitalization, but it's about the quality of life for our patients. What is there if we have no heart failure hospitalizations in 6 months, but the quality of life for our patients, it's not there, it's not optimal. I think it's extremely important, and I think we don't do it often enough.
So I'll chime in, and I certainly agree with everything you just said, and but I think of palliative care as somewhat of a holistic perspective. So it's going beyond just the cardiovascular problem, but it's thinking of the patient as a constellation of issues. And so I think it is an important perspective, and I agree that palliative care is both a very important part of best care, and it really should be implemented early for a heart failure patient who you know has a bad prognosis at any age, worse as they get older, but really at any age, and they often have a lot of social issues and other issues that really impact on their care. So palliative care, as mentioned, with resources, with a holistic perspective, really can add to the value of care. The only point that I really want to add and really emphasize is that palliative care is not giving up on the patient. It does not mean excuse or omitting guidelines-directed care. It does not mean omitting cardiac rehab. It does not mean omitting novel therapies and thinking about metformin and other things. I think of palliative care as really a reinforcement of best clinical care, but not hospice. This is not end stage. This is early, holistic management for a disease that has a very, challenging prognosis. So again, I think palliative care is good, but I really would preach that cardiologists and cardiovascular caregivers in general should really still maintain, aggressive treatment with a palliative care perspective, adding to the overall excellence of care.
Thank you both. I think it's so important to emphasize, that it really is about the quality of life and that it is not, there's the difference between palliative care and hospice. So thank you. Couple of other questions. There was a comment, SGLT2 are expensive and not easily accessible to many at this time. Do you see help in this area since the benefits are so great for the heart failure patient?
That's a great, fantastic question. And I'm sorry that I just jumped in to talk, Dr. Foreman.
No, go ahead.
I actually meant to say that during my presentation, and just, I got too enthusiastic and I forgot to mention that. Yes, they're great, but they're expensive. So you don't do anything, in my personal opinion, in prescribing this to a patient who's not going to be able to afford it. You're better off with prescribing those diabetes drugs or like those heart failure drugs that they're actually going to be able to afford and take consistently, and they're going to have the benefit from it. I think it's institution dependent. Here at Northwestern, we have a great program where patients apply and some of them get discounted prices, and we're able to bridge that gap and have the majority of our patients being on this. But it's going to take time, and I think effort from all of us to kind of provide these patients with these drugs that are wonderful but extremely expensive. So if you are stuck with a patient where you don't have the resources to provide that drug, then I would say choose something that also it's important and also has all those benefits, but it's affordable. Okay, that's my approach.
Yeah, I think that's a great answer, and I think that it's not just one drug class that's expensive. So many of the things that we prescribe in medicine are prohibitively expensive, and it's it kind of always shocks me when a patient suddenly tells me they have no insurance, and I start to look at what the prescription I'm thinking about is going to cost them, and it's overwhelming. So I agree that one is listening to our patients, finding out what their socioeconomic circumstances are, how what is their approach to how they're going to get their medicines. I think that's really relevant. It takes time. And I'm sure, like everyone else, it's very hard to find the time for me and for most caregivers. But I think, in terms of adherence and really having patients buy into your care, and that's both pills and it's also exercise, as we mentioned earlier, and diet. I mean, all these issues take money and time and effort, and for many patients, they're just not accessible. So I think we have to really listen to find the best strategies for each patient and tailor care.
Thank you. We have 2 more questions, and then we'll probably need to wrap up. But just going along the same lines of guideline-directed medical therapy, we had another question on, do you feel that Entresto is effective, and should we be utilizing this medication more? So similar lines to what we had just discussed.
Why don't you start?
Sure. I'm a firm believer in Entresto, to be honest. I think the data is there. I think the benefit it's there. We have it. But again, I don't do anything with sending a prescription to Walgreens or like Walgreens in my patient not being able to pick up the Entresto. However, some of the programs here, if I send like Lisinopril, it's free, literally no charge to my patient. So when I really look at the patient sitting in front of me, Lisinopril is a better choice. It's just there because they're going to take it because they don't have to pay for it. In an ideal world where everything would cost the same, I would definitely choose Entresto just because the data is there. But I think, again, it's going to take time and we're going to have to use resources and kind of like programs to be able to get these medications to our patients, unfortunately.
Yeah, and we have very similar answers again. And I agree. This question seemed to dovetail directly into the one that preceded it in terms of cost of medicines. And I do agree. I think the data for Entresto are very strong, and I think it's really a best first-line agent when patients will take it. And I for HFrEF, and I think it really makes sense to consider. But the one thing to emphasize again, it's the paradigm heart failure trial. Everyone, Clyde Yancey and many other pundits were saying this is going to change heart failure management. It is just one pill, and the heart failure patients are complex. So I think you have to really look at the composite, body composition, mood, so many other issues, diet. So again, I think the pill is really important, but it's not everything, and we have many other things to think about.
Great. Okay, how do you typically talk about the risk for heart failure in stage A patients? In working with patients that have already developed symptoms of heart failure, I don't hear a lot of them being aware of the actual risk for heart failure with hypertension or other conditions. More likely, patients understand the risk for stroke with hypertension, but not necessarily heart failure, at least in this person's experience.
I can start just because I think this is the flag I was waving with my talk. I think is, stage A can happen at any age, but as the population ages, as people are living with more diseases that compound risks for heart failure, I think it's increasingly prevalent. So I feel like for our society, with the especially in the midst of prevailing sedentariness, and hypertension, the untreated hypertension and hyperlipidemia, these issues are all around us. So I feel like I think the risks should be better highlighted, and I think the AHA is doing that, and I think other organizations are doing that. And for an aging, more complex society that's sedentary, I think these are very important messages.
I couldn't agree more with you. I think that's the key. Awareness and trying to incorporate it in our everyday clinics and like every time you see your patients and having those discussions. I think we're not doing it enough. I mean, one of the studies I presented, yeah, we're not really having those discussions with the stage A patients. And I think it's just also educating the medical community. Hey, like it's not just hypertension, diabetes. It's hypertension, diabetes today. Tomorrow it's heart failure. So let's just not there. Let's just intervene at the beginning of the bridge.
Thank you both. One last question and then we'll close out for today. We have one sitting there, so I think we can get to this last one and then close out. Thank you both again. How can nurses who follow up with patients in the community with heart failure start the conversation on palliative care when patients keep readmitting and decompensating from heart failure, but there is no mention on it from primary care or cardiology? So it sounds like primary care cardiology isn't addressing the palliative care aspect, but nurses following up with the patients would like to start to have that conversation. Do you have any advice for them?
I can start happily because, again, it's the care team. I think the care team is not it's too ambiguous. And I really don't think the nurses should be working out of step with the physicians, and the physicians, I think the agendas have to really meld together. And it's very sad to hear that the nurses are really petitioning for this, and it's not unified with the physician voice and the administrator's voice. And I think that this is where we are evolving. I mean, I would say that for me, and I'll just for a second say that the geriatric cardiology concept is similar, that, thinking of geriatric cardiology is thinking about the patient as a whole, just as palliative care is. And thinking when you prescribe any pill to a patient, and it's polypharmacy 101, and you're dealing with the difficulties of comprehensive care in the midst of multimorbidity, that overlaps with the concepts of palliative care. And I think geriatric cardiologists are growing, palliative care is growing. And I just think that it should be reinforced, again, by the AHA, which you're doing, but also by hospital conglomerates like the Cleveland Clinic and the Geisinger and Mayo. I think that these concepts really have to be embraced as part of the cardiovascular team. It's not just a cardiologist and a surgeon, it's the nurse with the primary care doctor with a unified voice for holistic care. And cardiovascular disease is just one part of it.
Yeah, I second everything you say, and I just wanted to add, first of all, thank you to all the nurses who do so much for our patients, who are actually there on a daily basis and actually getting to know our patients. I think it just makes a huge difference for them. And I think that the nursing-patient relationship becomes so deep and so intellectual that they're gonna feel comfortable opening up to you. So I think it's a great opportunity if you feel, hey, this patient has been readmitted, just sit down with the patient one of your visits and say, hey, what are your thoughts? How do you feel? Why do you think this is happening? What are your long-term goals? And kind of like circle back to the whole heart team and discuss that. And I think if you have the red flag, if you have that gut feeling that there is time for like palliative care to be involved, just go in and have that conversation.
Fantastic. Thank you so much, Dr. Manning and Dr. Foreman. Great presentations. Thank you to our audience for their engagement and the great questions, and both of you for answering them and sharing your expertise and perspective. We greatly appreciate it. Great kickoff to Heart Failure Awareness Week. Those of you that are on the line, you will be receiving a link to the recording of today's webinar within 24 hours. So we greatly appreciate everyone's time today. Thank you so much for joining. And with that, we will close out. Thank you again.
Thank you.
Thank you for inviting us. Bye-bye.